Good afternoon. Yes, I am an interventional radiologist at this institution. Well, they say that to prepare a good presentation, you need to adapt its contents to the audience, to your audience. The problem is that this is my first year as a presenter, and it was not easy to guess what the audience would be like. So I hope to reach at least some of your expectations for this session. Looking back in time, I thought it was shocking to see that this publication referred as permanent dialysis catheters as the great white tube of death. That was shocking for me. But it is true. These catheters cause a lot of complications. They dysfunction a lot. So it is a big problem. And what do we understand by dysfunction? When the catheter fails in providing an adequate blood flow during dialysis. This is defined by the Taulí guidelines as a flow not greater than 300 milliliters per minute during the first 60 minutes of dialysis, despite a first attempt to restore flow. This definition is a little controversial, maybe because it's a little bit old, and other parameters have been suggested to suggest catheter dysfunction, like high resistant pressures alert during dialysis. In any case, it is important to realize that only or less than 60% of the catheters are patent after 6 months. They increase the morbidity and the mortality of the patients, we know that, and they cause a great burden to the healthcare system. Of all accesses, tunnel catheters cause most of problems delivering adequate blood flow and require more interventions. I think it's interesting to see the distribution, the worldwide distribution of permanent catheters as a vascular access for dialysis. Taulí guidelines, again, recommend the prevalence not greater than 10% for patients in dialysis. And interesting to see that countries like Canada, for instance, have almost 50% of their patients on dialysis that are with a permanent catheter. Whereas in Japan, for instance, this access is not used at all. In other countries like Spain or the US, the prevalence is a lot greater than this 10% that is recommended. So it is difficult to reach that prevalence. Why do these catheters dysfunction? Why does that happen? Well, misplacement is it's a relatively common cause of dysfunction. If it's a malposition or a kink, that will cause an early dysfunction that we interventional radiologists should be able to depict in the angiosuite. Migration can occur, and rupture of the material, which is not very common at all anymore with the catheters we use nowadays, but it can happen, and the material of the catheter can migrate and cause problems. On the other hand, thrombotic-related occlusion is the most common cause of occlusion. That's the one we will be focusing on. And to understand this occlusion, we need to understand how the famous fibrin sheath is formed. The fibrin sheath, which in the end it will cause the occlusion of the catheter, starts its formation 24 hours after the catheter is placed. It starts where the catheter tip contacts the wall vessel, the vessel that has been injured when placing the catheter. This is what it looks like if we have to, once we remove the catheter that has been placed. And that's what happened only 1 week after placement. The whole catheter is lined by the fibrin sheath, and that's what we see when we remove these catheters. Of course, the fibrin sheath causes a decrease in the catheter flow that induces thrombus formations, and in the end, maybe pulmonary embolism when we remove the catheter, or infection. Many classifications have been published and proposed to try to explain what happens with these thrombotic-related occlusions. I like this one because this one was proposed by Besarab in 2011 because it correlates the pathological findings with the clinical symptoms or the clinical presentation. There are basically 4 different types of thrombotic-related occlusion. Type number 1 is the fibrin flap, in which the tail of the fibrin sheath acts as a one-way valve mechanism, occluding the catheter in a way that we can inflow, but we cannot aspirate what we are injecting. Type number 2, it's what we have just explained, the fibrin sheath, which is formed around the catheter. type number 3, which is a more serious condition, it's the mural thrombus, in which we will have no flow and we will have signs of central hypertension. In this case, the treatment should be a little bit more aggressive with systemic anticoagulation and so. And finally, type number 4 is the interluminal thrombus, in which we will have no flow and the fibrin sheath expands into the inner part of the catheter. Finally, another cause of dysfunction, which we will discuss later on, it's a central venous stenosis. It's more common in subclavian accesses and when they are on the left-hand side. So the first thing we need to ask ourselves when we face a dysfunction is it an early dysfunction? Did it occur the first 24 hours after placement? If the answer is yes, then we need to perform either a chest X-ray or we need to perform a fluoroscopic examination to rule out a malposition or a king. Like I said, these are complications that I think that we should be able to depict in the angio suite. I think the patient shouldn't leave our unit without depicting these complications, but I will show some examples. This is the correct position and aspect of a catheter located with the tip in the proximal right atrium. This is the typical location of a kink at the insertion site. That is more often when the puncture is too high. On the second set of images, what I'm showing is a catheter that has been inserted from the left internal jugular vein with one of the tips of the catheter inserted in the azygous vein. Remember that this shape, this angle, is very typical. Once you've seen this shape, you've seen them all. This is uncommon. This is a misplacement of a right internal jugular catheter with the tip in the left internal jugular vein. This is something we would see when placing the catheter. And the last one, I thought it was curious, but it's very uncommon. It's a catheter tip misplaced into a small persistent left superior vena cava. And those were uncommon situations, situations that are not so common, but this is a very common situation. The nephrologist calling us and saying, hello, good morning. I'm having low flows with the patient's catheter, around 200 milliliters per minute. I'm sure you remember the patient, because he or she had the same problem a month ago. And then interventional radiologists in our office, we have 3 thoughts. The first one is, indeed, the patient has a problem, we need to do something about it. Our second thought is, no, I do not remember the patient, I'm a radiologist. Radiologists do not remember patients by definition. And our third thought is the one most of the times we end up saying is, do you need it right away? So we will go on from this situation. We are facing a late dialysis catheter dysfunction. The first thing we need to rule out is a misplacement or a migration of the catheter. Are we facing that? Let's perform a chest X-ray or a phlebography later on to see if that is the case. If that is the case, we need to either reposition or, most of the times, replace the catheter. This example here is showing a catheter that has been where the cuff has been extruded, and the tip of the catheter is now in the superior vena cava. In this case, this catheter was dysfunctioning. They don't always dysfunction when they are extruded, but in this case, there was a migration. So we replaced it. This is another case of a migration of the dialysis catheter into the azygous vein. As you can see, the catheter is redundant. So if you have ruled that out, there is no misplacement, then you are facing an occlusion. So you need to ask ourselves, is it a thrombus or a sheet? I don't know. Maybe it's both, because these entities tend to overlap. It's very nice to classify them and to separate them, but they overlap. And one thing leads to another. So the first thing we need to try is thrombolysis. And why? Why is our first step? Well, thrombolytic agents are widely used to treat catheter thrombosis. They've been used for over 20 years. They are safe and efficacious, at least to maintain and restore the flow in the short term. They have low incidence of complications. They are cost effective. And very importantly, very importantly, they are minimally disruptive for the dialysis run. This is very important for these patients. Still, although we are comfortable, or nephrologists are comfortable and familiar with thrombolytic agents and the different set of protocols, there are still certain uncertainties. Which is the best agent? Which is the best thrombolytic agent? Is the local treatment better than the systemic one? Is the dual protocol better than the push protocol? What's the best dose or time for treatment? The truth is that the most effective administration protocol to treat catheter dysfunction remains unclear. Finally, after going over the literature and reviewing the different agents, thrombolytic agents, I came up with this table in which I try to summarize them all. In Europe, we have a very wide experience with urokinase. There are many different protocols that are recommended in various guidelines in the States. Alteplase is the only one with FDA approval. In the end, there are no randomized control trials comparing the different thrombolytic agents to one another, although, like I said, they are effective and we feel confident with them. If that fails, if despite using a thrombolytic agent, you fail to restore patency of your catheter, or of the patient's catheter, which is very often, at that point you will be in the 70% of the cases, you need to mechanically disrupt the fibrin sheath and or replace the catheter. And I would love to tell you that I have the perfect solution for that. As an interventional radiologist, I have the perfect solution to disrupt the fibrin sheath and to restore flow and to preserve it in the long term. But I'm sorry, I don't have the perfect, we don't have the perfect solution for that. The outcomes are not so good for the patient in the long term, and we can restore flow. Actually, we will discuss the literature in a minute, but we don't have a perfect solution for the fibrin sheath. We are very far from that. We have 4 different tools to break down the fibrin sheath. I will explain them very quickly so that later on it's a lot easier to understand the rest of the presentation. 4 different tools: brushing, which is not currently used anymore, or at least is not the treatment of choice; angioplasty, followed or not by catheter exchange; and stripping. Brushing, very rapidly, consists of introducing either a guide wire or some other kind of device, like a urethral brush, which I've never used, to be honest, to disrupt the tip of the catheter. We will discuss the results of this technique later on. Angioplasty. It consists, this is a phlebography performed from a catheter inserted in the right internal jugular vein. We can see the fibrin sheath very clearly, and what we do is we introduce an angioplasty balloon. We inflate at the end of the tip. Well, once we have removed the tip, we disrupt the fibrin sheath, and this is our final result. Most of the times, at least here, we exchange the catheter afterwards. Stripping. Stripping is a little bit more complex. This is the fibrin sheath again. And what we do, we need an additional access, a right femoral access, and we introduce what we call a snare catheter that we bind around the fibrin sheath with or without the catheter, and we pull the sheath down. This is the way we disrupt it. Note that we need an additional access, so it increases the morbidity of the procedure. And this table tries to summarize the results of the different techniques. Thrombolysis has also been included for some reason, but brushing is not here. The evidence is not very consistent. Most of the studies that have evaluated the efficacy of all these procedures are retrospective with very small samples of patients and not comparing one procedure to the other. There are very few randomized controlled trials that compare the different techniques that we will discuss in a minute. But it gives us an idea of what happens most of the times. What happens is that we have a very high technical success. We are very effective in disrupting the fibrin sheath. So when I leave the angio suite, I'm sure that the patient will do the dialysis session without problems. I know that the procedure is safe for the patient. They will have very low complication rates. But on the other hand, the median primary patency is is not acceptable. It's low. It's not as good as we would want it to be. There are not that many studies. You will see that they have a lot of limitations, but I will go over them very quickly. This study, published in 2000, compared stripping versus thrombolysis versus urokinase infusion. They found no differences between the two treatments. As you can see, the samples, it was a randomized control trial, but the samples were quite small. I don't know what would have happened if they had been bigger. This other study, comparing stripping versus catheter exchange, did find that catheter exchange was more effective and more cost-effective. Again, the samples were not so big, but that is what they found. I have to say, though, that in this study, the patients undergoing catheter exchange, 20% of the patients undergoing catheter exchange underwent some kind of procedure to disrupt the fibrin sheath. So I don't know if really we can have a clear conclusion of this study. This other study comparing catheter exchange versus catheter exchange and angioplasty versus fibrin sheath stripping, this was a retrospective study and found no differences. But again, look at the samples, 15 patients, 33 patients, 18 patients. I don't really know what would have happened if the methods had been a little different or a little improved. Finally, this is interesting. This was a pilot study, unfortunately only a pilot study, conducted in 2010 and 2007. It's a randomized control trial that compared catheter exchange versus catheter exchange and angioplasty. They did with catheter exchange and angioplasty, they did improve some parameters that are studied during dialysis, like the flow and the urea reduction ratio, but the problem is that the survival curves, there were no difference in the survival curves after all. The amount of, again, the samples were small. This was a pilot study. They never published or never completed the study, but it would have been interesting. Brushing, very few things about brushing, because there are very few retrospective studies with very few patients, various success rates reported, no long-term follow-up, different devices to perform the procedure. These two studies are probably the most relevant ones, but in the end, the conclusion is that although brushing can prolong a little bit the short-term function, it only affects the long-term catheter survival in a minority of patients. Finally, only a few words to discuss central stenosis, which is a complete different story. In this case, intervention should be considered with caution because of the risk of re-stenosis. We have to wait until the patient is symptomatic. We have to wait until the catheter really dysfunctions to perform a procedure. Why? Because angioplasty increases the inflammatory process around the stenosis, and the need for intervention also increases. The technical success, the immediate technical success is quite high, but the primary patents at 6 months is very variable according to the literature. Stenting is another option. It might be beneficial for residual stenosis after angioplasty or recurrences after less than 3 months. High technical success again, but the primary patency at 6 months, it's variable according to the different studies. Take-home messages. First, when the catheter is dysfunction, rule out misplacement or migration, perform a chest X-ray. If you are facing an occlusion, first try thrombolysis. Secondly, try an endovascular intervention. Remember that fibrin sheath stripping and brushing are not recommended anymore. They can be used in very specific cases, but they don't seem to be very effective, and they are not cost effective, at least stripping. Catheter exchange is a little better, seems to be a little better, and catheter exchange and angioplasty is the technique of choice. Although, like I've been saying, we need more and better studies to compare the different possibilities that we have. And remember that early detection of catheter dysfunction is crucial for the patient's outcome. Only 1 minute to thank my colleague, Eva Criado. She should be the one giving this presentation here today, and she's always very supportive. She's in Pittsburgh, so I wanted to thank her. That's it.